Welcome to the Teaching Value in Healthcare Learning Network. Come join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health system innovation to train a new generation of healthcare providers from diverse specialties and professionals skilled to deliver high-value care. With national concerns about rising healthcare costs as well as overuse, underuse, and misuse of medical care, the cost of care and the ABIM Foundation created the Learning Network as a space to share ideas, educational materials, and strategies in an open forum. Our goal is to discuss ways to get started, implement, and sustain feasible interventions in teaching value at your institutions. I'm Daniel Wolfson, the Executive Vice President of the ABIM Foundation, and I'm moderating today's webinar. Today, we will share an innovation in teaching value with Dr. Neil Wenger, who will discuss the UCLA Advanced Care Planning Model. Dr. Wenger is a professor of medicine in the Division of General Internal Medicine at UCLA and a consulting researcher at RAND. He's a practicing general internist, researching decision-making for older patients and quality of health care at the end of life, and directs the NRSA Primary Care Research Fellowship. He also directs UCLA's Health Advanced Care Planning Program, which aims to increase caring for patients with advanced illness at the right time, in the right place, by the right teams, a model of UCLA's Office of Accountable Care and Population Health to promote value and patient-centered care. Welcome, Neil.
Thank you so much, Dan. So I'm going to talk a little bit about the UCLA Advanced Care Planning Model. Why does UCLA need to dedicate effort to developing a specific advanced care planning model? Well, because we, like many other academic medical centers and actually tertiary care hospitals throughout the country, usually operate on one speed, and that's do more, save the patient, do whatever is possible. And that speed usually works quite well, which is why we have really successful outcomes. But the fact is that that speed doesn't necessarily account for patients' preferences and what their goals might be. And that's why advanced care planning has to happen. Advanced care planning has been around for a long time. That's these conversations about prognosis and preferences that occur between patients and their doctors and families that then outline the kinds of care that people would want as they get sicker, and especially toward the end of life. And while we know that these conversations should happen, and we even have advanced directives available and things like Healthcare Decisions Day, which is a national day to remember to do advanced care planning, we don't often incorporate that into the care that we provide. And because of that, we often reach situations where patients are not doing well, but we don't know exactly what they would want in that case. So we developed an advanced care planning model at UCLA that explicitly tries to incorporate advanced care planning at a variety of different places within the care spectrum and the progress of medical care. That it should become a natural part of patient engagement, something that's actually expected that it happens, that it would get appropriately introduced at the right time with the right content, that there would be prompts to help clinicians know that they ought to be thinking about advanced care planning and they ought to be raising it. A focused iterative conversation about goals of care that occurs when the patient is ready and when a patient particularly needs it. And just as importantly, a way to make sure it's documented within the healthcare system so that others know this conversation has been started, they can pick it up and run with it, and the decisions that get made then direct the kind of care that patients desire because we know what they are at the point of care. And in order to do that, we've needed to create infrastructure at UCLA to take our electronic health record and make sure that it's ready for advanced care planning, and it incorporates goals of care notes, and people know where to find advanced directives and other documents. And we've undertaken a variety of different initiatives that look at patients in all different circumstances. Now, when we think about advanced care planning, we think about the sickest patients. And in fact, that's where most of our efforts have focused. But not only there, we've also thought about primary care and try to incorporate the whole variety of different sorts of clinicians. In order to do this, we needed to get institutional buy-in. So we created an advanced care planning design team. This is part of our primary care innovations model, where we have individuals from throughout the entire organization coming together on a monthly basis. And we discuss areas where there's need, how our interventions are going, and what next steps might be. We have clinicians, we have doctors, nurses, social workers, respiratory therapists, people from spiritual care, palliative care is well represented, administrators. We have some students and residents. And this group comes together every single month, and we discuss whether our initiatives are being successful or not. So briefly, what are some of our initiatives? We recognized that among some of our sickest patients, we weren't raising the issue of prognosis and their goals early enough. So we took one group, patients coming into our hospital hoping for a heart transplant or some kind of mechanical heart support. And we implanted a social worker to discuss future healthcare states and advanced care planning with every single patient admitted to the hospital or seen in the outpatient setting to have this conversation. It took a while to get it integrated, several months, but after that period, this became an expected part of the workup of a heart transplant patient or of a patient coming in who might get a left ventricular assist device. And in fact, now, if in fact the social worker can get to a patient early enough, the cardiothoracic team actually sees this as a lacking in the care of this patient, which is the kind of thing that we consider to be a success in care process. For every single one of these patients, some conversation occurs. As you might expect, not everyone coming in to get a heart transplant is willing to talk about future health states and whether they're willing to have medical care keep them in it. But in fact, it turns out that 3 out of 4 patients are willing to have these conversations. And we've now begun to disseminate this to other highly complex patients in very sick groups. One other innovation that I'll tell you about is that we have continuity care coordinators in every one of our primary care clinics. These unlicensed individuals have very, very good people skills. And their job is to interact with patients to make sure they're part navigator, part care coordinator. Their job is to make sure that patients get all the care that they need and that the doctors have an individual to help them get the kinds of care that are difficult for doctors to achieve. So they're the ones who make sure that DME happens. They're the ones to make sure that hospice shows up at the house for the outpatient. They're the ones that make sure that the medication that was refused after the appeal of the prior authorization actually gets approved because the appropriate kind of appeal occurs. And they learn very quickly how to interact with these patients. They also are dealing with the sickest primary care patients. So we trained them to understand advanced directives, to get to know which patients need to have the advanced directives, to introduce advanced directives to patients, and to tee it up for the doctors to then carry on the conversation. They also, we're here in California where we have POLST forms. They also, when they deal with a post-discharge patient, will look to see if this patient had a do not resuscitate order in the hospital. And if they did, do they have a POLST? A POLST is a physician's order for life-sustaining treatment, and you can put a DNR onto that form that will then travel with the patient outside the hospital. If the patient was discharged without a POLST, they will let the doctor know, gee, you're going to see Mrs. Smith next week. Here's a post form for them. Think about whether it's appropriate for this patient. And in fact, this care coordination, teeing up advanced care planning for primary care docs turns out to work really well. These are just two of the innovations that we've instituted to actually bring advanced care planning, bring this model to life within a health system that really focuses upon heart transplants and liver transplants and caring for the most complex patients.
Thank you very much, Neil. I wanted to ask you, in advanced directives, the problem we've seen is that, at 4 o'clock in the morning, nobody can find the advanced directive. And I imagine it's true with advanced care planning plans that, that document is not widely shared with a team, or the team changes. So what systems do you put in place that combat that kind of non-compliance, if you will, with patients' wishes?
So that is an excellent point. In fact, we have those problems here as well. But the infrastructure that we built, which we actually carried over into our EHR when we instituted it in 2013, was to have a goals of care note tab, where advanced care planning gets documented as a goals of care note in this tab. That's the only thing that is in this tab in the EHR, and it's easily found. And it can be built upon that way. So let's say that I meet a patient and I begin to talk with them about future health states, and they turn green and run out of the room. I realize that maybe I didn't handle it appropriately, but I can also document in the goals of care tab, here's someone who's very well defended, and it will be difficult to perform advanced care planning with them. When the social worker sees them in the hospital, they can look at my note and they'll approach the patient differently than I did, hopefully, and perhaps make some progress. What we have found is that notes get put into the system one on top of the next as the patient develops prognostic awareness, as people begin to understand their prognosis, and as they start to make decisions. And everyone knows where to look for those notes within the goals of care tab. We have a separate tab for advanced directive and post forms. Hopefully, all the advanced directives are collected in there, but I'd be lying if I said that that system is perfect.
The advanced directive post, advanced care planning model, give me kind of just an idea what the difference is. And, these kinds of conversations are not easy. Where does a resident or a medical student begin to learn about how to have these conversations?
So you're absolutely right. These conversations are not easy, and they're not second nature, and they're actually pretty easy to botch. And what we have learned is that we need to integrate education about advanced care planning everywhere that we can. So when an intern first shows up at UCLA, there's a day of orientation. We have a little bit of advanced care planning in there. In every residency program, they give us blocks of time to practice having these conversations. With certain groups, such as oncologists that are sometimes the most resistant to having these conversations, the institution miraculously has actually given us 4 hours with all the oncologists to actually do some role play and have them practice. Now, is that enough? Probably not, but it's certainly a foothold, and it's having the buy-in of the institution that these are important conversations, that they'll give you the time slots to be able to practice them. That is really critical.
So how did you get the buy-in from the institution? That's often a difficult obstacle.
Well, that's an interesting question. I think we have a relatively innovative leadership here, and they tend to understand that it's important, but probably even more important than that is the fact that poor advanced care planning leads to poor outcomes for patients receiving very aggressive treatment. Those poor outcomes tend to be really expensive. and they drive away the contracts that the institution wants. So there is a financial incentive for the institution to develop high quality advanced care planning. And I think it's probably that more than anything else that has led them to support our efforts.
I'm probably in the 1/4 if you came to me and I was having a heart operation and you said, advanced care planning, let's do some of that. I would probably flee. So how would you bring me back to the conversation?
So what we teach when we're doing advanced care planning is that in this process, you never push. You don't want to break down that wall unless there is no other choice, right? If in fact you're the intern caring for someone at 2 o'clock in the morning who just got admitted that you've never met before and you're about to intubate them, you may not have a choice. That's the worst possible circumstance. I would say that's probably a failure of advanced care planning. And you might need to ask the question that you don't want to ask. But otherwise, we don't force it. We simply raise the issue. It turns out, at least in my experience, and we have actually a lot of experience now to bear this out, that if you simply raise the issue, it begins to make the patient realize that this is a permissible topic. And if it's a permissible topic, the next time it gets raised, there might be a little bit more openness to it. And I'll tell you a story. A couple years ago, I happened to have 2 elderly gentlemen, both with metastatic cancer. And in each case, I tried to raise the issue of advanced care planning. And in each case, their wife that was with them at the visit stood in front of me in order to stop me from talking to the patient. I was shocked the first time, and the second time I thought, oh, this is a phenomenon that appears to be happening more than once. Not more than 2 or 3 months later, we were in the hospital, and the patient was now much sicker. The wife of the patient comes out to tell me, you remember that time where I stood in front of you and wouldn't let you talk to my husband? Now we need to have that conversation. Simply raising it, even if one doesn't make progress, very frequently is an important first step.
Are there some cultural differences that you see in the population regarding advanced planning?
There are enormous cultural differences, and not being sensitive to those is a real problem with advanced care planning. We actually spend a lot of time thinking about how different sorts of people approach these topics. It's really important to recognize the cultural differences, but not to necessarily assume that they're present, because we'll be probably wrong more often than we're right. Being sensitive to them and being sensitive to the body language of the patient, being sensitive to the responses that one is receiving, very frequently leads to a smooth conversation. So now, let me point out that we're trying to get advanced care planning to occur in the outpatient setting. That leaves enormous flexibility. That means if I don't have the conversation today, I can bring it up with you 2 months from now at your follow-up visit, or perhaps even 6 months from now. In my experience, bringing up the conversation allows this iterative process to occur, and in fact, advanced care planning is then successful by the time it's needed.
Neil, what are the 2 biggest challenges that you have regarding advancing this kind of planning?
That's a good question. I think the biggest challenge is time. It does take time to do. Clinicians who are not skilled at it see it as something that will take a long time, which it usually doesn't. And therefore it never gets raised. The second, I think, is the skill of the clinicians. And that's something that takes a long time to teach. We might teach our residents, but if the attending physicians don't feel skilled in it and don't do it, the residents quickly unlearn that skill that we're trying to foster. And there's one other really important part, and that's the expectation. Do the clinicians have the expectation that in fact this is going to happen, right? My dream is that I'm walking down the hall one day and I hear one doctor say to another doctor, gee, you know, you've been taking care of this patient with dementia. And when I went to go talk to her, advanced care planning had never happened. Wow, why did that occur? Never in my life have I heard that occur, that conversation happen. I'm hoping someday, before I retire, that I'll hear that conversation.
There must be a huge trust factor here between patients and clinicians. Can you address that?
Tell me more.
Well, if there's not a trusting relationship between the two and it's not an established relationship, these conversations are a lot more difficult.
Oh, absolutely. If in fact a patient doesn't trust that their physician is going to provide all the medical treatment to achieve their goals, then an advanced care planning conversation is almost certain to fail. There has to be trust. And in fact, the places that we see advanced care planning go least well is where patients have had difficulty accessing medical care over time. Why should they believe that discussing future states that they don't want to be in will be respected if they haven't been able to get the medical care that they needed up until now?
Great. Neil, thank you so much for being on with us today. It was a really interesting and important topic, and thank you so much.
Thank you.